So what about telaprevir? There was a large study called REALIZE, which looked at the effectiveness of this treatment in previous treatment failures. And again, similar type of design where you have the standard dual therapy plus 2 groups that received the telaprevir for 12 weeks. This arm included a lead-in period of interferon and ribavirin alone to see if it made a difference, as opposed to starting the telaprevir right at the beginning. Again, these groups got 12 weeks of telaprevir. And this is the response according to your previous response to peg interferon and ribavirin. And so you can see the relapsers, they did it extremely well, 83 to 88%. This is actually higher than if you were treatment naive. Remember I showed you it was about 69 to 75%. And this is because these relapsers have demonstrated a responsiveness to antiviral therapy already. So they're a selected group that are more interferon responsive. The second group, partial responders, are shown here. You can see close to a 60% chance of response. And then the null responders, or those who had no response to dual therapy, they have about a 30% chance of response if you treat them with telaprevir. You can see it was only a 5% chance if you retreated them with peg interferon and ribavirin, so pretty dismal. So a significant improvement in response rate. Now this is a very busy slide, but I think it's important because it shows the response rates according to your previous treatment response and the severity of your liver fibrosis. We heard from Dr. Krajden that the priority for patients, patients to treat soon are the ones with advanced fibrosis because they really need it. Okay? What this shows is that if you're a relapser and you have cirrhosis, well, it doesn't make a big difference. If you have mild fibrosis, moderate fibrosis, or cirrhosis, you have about an 85% chance of cure. So that's the good news. Okay? This is the bad news. If you were a prior null responder and you have cirrhosis, well, you only have a 14% chance of cure if you received triple therapy, including telaprevir, versus only 10% if you got dual therapy. Okay, so there are a lot of patients who have advanced fibrosis out there. If you were a prior null responder, it tells us that you're probably going to need to be treated with one of the newer drugs coming down the pipeline, as opposed to these first-generation protease inhibitors. So our treatment algorithms for patients with telaprevir and not cirrhosis are that relapsers, they get 12 weeks of triple therapy, and if they're negative at week 4 and 12, they stop the telaprevir then, and then get an additional 12 weeks of double therapy. If they don't have this good interferon response, well, they get a similar regimen, but they get a 36-week treatment tail of the dual therapy after the triple therapy. If they're a partial responder, null responder, or you have cirrhosis with and you're going to be retreated with telaprevir, then our recommendations are that you get the triple therapy for 12 weeks and then an additional 36 weeks of dual therapy in order to maximize the responses. So you can see that depending on your previous treatment, your severity of liver fibrosis, and which drug you're using, that the regimens or recommended algorithms, they all differ. So hepatitis C treatment is getting more complicated, and I think that this is a problem. I think that what a lot of experts think is that maybe people who don't treat very many patients, they might start getting out of it because it's more complicated. And so we heard that we need to try to maximize the number of patients on treatment. The fact that these regimens are getting more complicated might have a deleterious effect in terms of patient numbers that can be treated. So that's all the good news about the treatments, the new treatments. What about the adverse effects? What we know is that these drugs are associated with more adverse effects than if you received peg interferon and ribavirin. And they differ slightly between which medication you use, telaprevir or boceprevir. So the major side effects that were seen in the clinical trials with telaprevir were itch or pruritus, rash, and anemia. You can see that roughly half of people became itchy, about 40% got rashes, and about 40% became anemic. Okay? And remember, interferon and ribavirin on their own cause anemia. If you've been through this treatment, you'll know that. So this drug makes it worse, and so does boceprevir. What about this rash? You may have heard about this rash. In the majority of cases, it's mild. However, you can see here in 6% of patients who got telaprevir for 12 weeks, they had a severe rash. And in some patients, you need to stop the telaprevir because of the rash. In that study, it was about 7% they stopped for rash. Okay? So rash is something that certainly we've seen. We need to be on the lookout for it. As I mentioned, most of the rashes are mild. They usually occur within the first 4 weeks. They're usually localized, and they'll respond to topical treatments like steroid creams or antihistamines. Normally, we'll continue the telaprevir in those situations. Again, use these antihistamines or topical steroids, and as well making sure the skin is very moist. We don't use systemic steroids like prednisone to treat this. If the rash is more moderate, there may be some skin peeling. It may be more extensive. Generally, we will continue the telaprevir. However, you need to keep a close eye on these patients. We'll use similar management otherwise as with mild rash, although we may refer to dermatologists. It's important that if ultimately you discontinue the telaprevir, that usually the rash will respond within a week or so. So it tends to be reversible. And then there are severe rashes, which can affect more parts of the skin and also the mucous membranes, for example, the inside of the mouth. These are severe, and that's a medical emergency. In that situation, you need to discontinue the telaprevir immediately and get your dermatology colleagues involved. It's important to note that these severe rashes have been noted in the clinical trials. They can be fatal, although no fatalities have been reported thus far. So another unusual side effect with telaprevir is our anal rectal symptoms and signs, and these can be anywhere from perianal itching or burning. This happens in nearly a third of patients who are treated with telaprevir, and normally this responds to topical therapies. And if you stop the telaprevir, it goes away. I put this slide on here so if you're going to be treated with this, you're aware of the potential for this side effect. And one of the big issues with these new drugs is anemia. And this is data from one of these clinical trials I mentioned, which looks at telaprevir versus standard therapy. And this is the hemoglobin level over time on treatment. And with the standard therapy, it's shown in red here, you can see that the hemoglobin dropped in this study from on average from about 150 down to about 125 within 4 weeks. Okay, it sort of reaches its low point around 8 to 12 weeks, and then it generally stabilizes. Look at with the telaprevir, you can see in blue, you can see a more rapid reduction and a lower level of hemoglobin. So the hemoglobin level is usually about 10 to 20 points lower if you're on telaprevir than if you're on the double therapy. Now, I'll skip that. What about boceprevir? I think I'm running out of time. What about boceprevir? Well, there's some similar side effects. Anemia is one. And something that's interesting is what's called dysgeusia, or abnormal taste in the mouth. So anemia with boceprevir, you can see that it happened in about 50% of patients who were in the clinical trial. Severe anemia, or less than 85 grams per liter in our Canadian units, happened in 5 to 10% of patients. So it can be quite significant. Now in this trial, about 40% of patients were put on erythropoietin, or EPO, which can help support the hemoglobin in those patients. We don't have that readily available in Alberta. I'm not quite sure about in British Columbia. Now what happens, how should we manage this anemia? I think that this is very important, particularly for patients who have treatment. What we know, or physicians who do this treatment, what we know with the previous therapy, interferon and ribavirin, is if you drop the ribavirin dose due to anemia, that the response rates weren't as good. Okay? What we know with these new drugs is that if you lower the dose of ribavirin, that you don't really see a loss in cure rates. Okay, so what we're advising physicians who are treating patients is to be more aggressive with ribavirin dose reduction if the patient becomes anemic, because it really won't impact the rate of cure with these new drugs. So that's good news. So just in terms of anemia management, obviously expect it. This is happening in nearly half of patients who we're going to treat. We need to make sure that the patient's iron and B12 and folate stores are appropriate. And we're going to need to be monitoring patients more closely on these drugs. And as we get more used to using these drugs, I think that even weekly monitoring of the blood count should be done. As well, we need to do frequent cardiac testing, I think, have a lower threshold for cardiac testing if we're going to be using these drugs, because if somebody has an underlying coronary artery disease, which is undiagnosed, they could have complications on therapy due to anemia. Again, you need to really respond aggressively to this. And traditionally, we've often just lowered the ribavirin down by 1 pill or 200 milligrams at each step when a patient gets anemic. Now, I think we need to drop straight down from about 1,000 to 1,200 milligrams all the way down to 600 milligrams, because we know that doesn't make a difference in terms of treatment response. Very important that we can't reduce the doses of these new protease inhibitors, because that predisposes to antiviral resistance. So if you're on that one of those protease inhibitors, you don't change the dose. Okay, you're either on it or you stop it. And then what we are also noticing is we're needing to use a lot more blood transfusions with these new medications due to the severity of the anemia. Something I think is very important to be aware of are potential drug-drug interactions with these new medications. And so the metabolism of these drugs is a bit complicated, but what we know is that they're cleared by a certain enzyme system in the liver. It's called cytochrome P450-3A4 or CYP3A4. And there's also this other system called P-glycoprotein. And so telaprevir and boceprevir can inhibit this enzyme. Okay? So if you're on another drug which is cleared by this enzyme, then if it's inhibited, the drug level is going to rise. Okay, so that can cause problems with a whole variety of medications which you might be taking due to increased exposure. And then on the flip side, these drugs can induce this, these other drugs can induce this enzyme which clears telaprevir or boceprevir. So those levels can go down. Okay, and so then you'll have less effective triple therapy if the drug levels have gone down. And so there's a whole bunch of medications which which we as treaters really need to be aware of if we're going to be using these direct-acting antivirals. Most drugs to control seizures are contraindicated. Statins like Lipitor, Crestor, those cannot be used with these protease inhibitors. So lots of people are on those these days. The good news is treatment is only for 24 to 48 weeks with this triple therapy. So in most cases, if you stop your Lipitor or whatever for a short period of time, it's not going to make a difference from a cardiac point of view. Midazolam is a sedative we use to do endoscopies frequently. You can get increased exposure to that drug, and basically a patient may take a long time to wake up after they have an endoscopy. So we don't use midazolam in that situation. Very important one for the women are oral contraceptives. So these drugs will induce the enzyme that metabolizes those, so they'll be less effective. So you need to make sure you have another method of birth control. We heard a bit about HIV infection. Well, there are drug-drug interactions with highly active antiretroviral therapies that need to be considered. So if patients with HIV are being treated with these drugs, we certainly recommend that the treatment is managed by experts in the field. And then lastly, another important group with hepatitis C are the post-liver transplant population who have poor responses to currently available antiviral therapies. And there are important drug-drug interactions with the immune suppressants used in this situation. So again, the drugs aren't approved for this indication. So if these patients are going to be treated post-transplant, they need to be treated by experts, preferably in clinical trials. These are a couple useful websites which detail all of these drug-drug interactions. And so certainly we're recommending that treaters and patients, if they're going to be using these drugs, that they look up these websites to make sure they're not on any drugs which are contraindications. So I'm nearly done, and just a brief word about antiviral resistance, because this is something we didn't really talk about with PEG interferon and ribavirin. These drugs we're recognizing resistance with these medications, and some people think it's because the medications cause resistance. Well, in fact, that's not the case. Resistant mutations in the virus are present in everybody who's infected, but they're just at low frequencies which aren't detectable by our currently available means. And what happens is when you put somebody on these drugs, the resistant, the normal hepatitis C virus gets suppressed, and that lets the resistant variants essentially rebound and become detectable, okay? But it's not due to the medication, it's just unmasking underlying resistance, okay? Some have suggested that we should be doing resistance testing to look for these resistant mutations, but we don't think that's useful at the moment. Now, very important, the PEG interferon and ribavirin that you're on with these medications, those actually help prevent emergence of resistance, okay? If you're on one of these direct-acting antivirals and you need to stop the interferon or the ribavirin for whatever reason, you need to stop the boceprevir or telaprevir. And as I mentioned, you shouldn't lower the dose. Very important you're compliant with these medications. They have to be taken 3 times a day. It's tough. But if you're not compliant, you could predispose to resistance as well. And then lastly, I told you about those stopping rules. It's very important we adhere to those stopping rules, because if you don't, we'll get emergence of resistance. For the sake of time, I'll skip this. I see Fran's ready to give me the yank. So just in terms of summary, I think if we really want to make a difference in terms of hepatitis C morbidity and mortality, we need to maximize the number of patients we're diagnosed. We need to refer them. We need to get them on treatment. These barriers to treatment, a couple of them I talked about extensively, biopsy or a minimum requirement for fibrosis. I think we need to get rid of those. They're big barriers in our practice. And these new therapies, they are going to increase response rates in patients who are treatment naive as well as treatment experienced. These are only in patients with genotype 1. And we need to remember that the regimens are complex. They do have side effects. We need to think about resistance, and we need to think about drug-drug interactions. So thanks for your attention.
I'm just going to make a comment, again from a nursing perspective. Dr. Myers mentioned that the complexity of therapy may drive less patients towards treatment. In the Central Island, we're a small community, and what we wanted to do was to make sure that that didn't happen. So in October of last year, we started 4 patients on therapy with triple combination. And of those 4 patients that we have on treatment, at this point in time, I have 2 of those patients that may, at week 24, discontinue treatment at a 28-week therapy rather than 48 weeks. It's doable, but it's extremely hard work, so it's a challenge. But what the take-home message is that the new treatment modalities that we are using are giving patients hope. Thank you. So questions, please. So load, he's taking a post, stick it into there, and then it's on your
Hi. Dr. Myers, I wonder if you could just comment on why all these rectal problems. Is it because of constipation? Do the drugs cause constipation, or what's the story there?
That's a great question. It's not because of constipation. I'm not sure of the exact mechanism. I'm not sure that that's been elucidated. It's only with telaprevir. It's not with boceprevir, so it seems to be specific to that medication, but I'm not sure the pathophysiology, to be honest. Okay. Not due to constipation, though.
Yeah, when you hear hemorrhoids, you're right away thinking, constipation issues or whatever, and whether there's something easy that you could offer patients that would help control that.
Yeah, I mean, you use perianal creams, for example, but I don't know.
Well, yeah, I'm thinking the external things, but whether there's something they could be taking internally that would help.
Yeah, to be honest, I don't think really anything's been proven to improve that. But
okay, well, thank you.
And in nursing terms, we call it firea.
In answer to that last question, I believe that they're finding out that when you take your medication, if you take it with a large, is it 20 or 30 grams of fat with your meal, you will have a lot less problems. It's to do with the absorption of the medication, and if it doesn't get absorbed through the stomach and through the other systems, it will be eliminated at the other end, and that is what's causing a lot of the problems.
Yeah, certainly, I didn't mention this, all I mentioned was you have to take these medications every 8 hours, but there are dietary recommendations as well. With telaprevir, for example, you should take it with a high-fat, 20-gram fat meal. That is important.
Hi, I wonder if you could maybe just talk a little bit about the rash that you're mentioning and how it can potentially be fatal. What exactly is that all about?
Yeah, so there's one of these is called Stevens-Johnson syndrome, for example. Severe rash over a large part of the body with blistering, peeling, you get mucous membrane involvement, and the mortality in patients who get that, and it's not just caused by these medications, there's other causes of that, is largely related to fluid losses and infections. You can imagine if you have such severe skin breakdown, you can get infection. So these types of things were rarely reported in the clinical trials of these medications, predominantly telaprevir. But like I mentioned, no deaths have been reported. So, you know, the important thing is that if you have a severe rash, you know, we need to deal with it, you know, emergently.
Okay. Thank you very much.
Dr. Meyer, what are the possibilities of a breakthrough patient responding to triple therapy?
Yeah, if somebody, one of my last slides was actually showing this breakthrough issue, but I zipped through it. They won't respond. So we know, for example, my slide was showing an example patient on telaprevir. And one of the stopping rules is if at week 4, it's over 1,000. Well, we know actually that most people respond within 2 weeks of these medications. So if at week 4 they're say over 1,000, what we know is that they're not sort of gradually going down like this, that they've gone like this and now they're coming out. And so those are breakthroughs. They won't respond.
Hello, I'm a hepatology nurse clinician from Vancouver, and I just want to take this opportunity to mention that there are a couple of drugs that are contraindicated for concurrent use with both biopsy and telaprevir when used for pulmonary arterial hypertension. By their certain names, but those same drugs have 2 different names, Viagra and Cialis. So I think it's really, really important that patients are aware that it's not just the DAH drug use where there's a concern, but it's also the erectile dysfunction use.
Yeah, I mean, that wasn't on my slide, but certainly those and the various antibiotics, medications to treat certain mycobacterial infections, lots of medications. So that's a good point.
The other one as well is herbal medications. A lot of patients are taking things like St. John's wort, and that is contraindicated. And we have to be extremely careful. Anything a patient puts into their mouth when they are taking triple therapy needs to be assessed by the physician and the nursing component.
We're telling our patients if we have them on therapy that if they get told by anybody to take any medication, they need to check with our nurses first. It's the safest thing to do, I think.
We have another question just up here. Oh, sorry.
Oh, yeah, I was treated with telaprevir a couple of years ago, and I failed. My viral load increased about week 8. A few things I wish I knew before I went on treatment that might have helped. Some studies have shown that people taking vitamin D have doubled their chances of SVR. And other studies have shown that people who drink 3 cups of coffee a day also can double their chances of SVR. And improve their quality of life through reduced progression through fibrosis or cirrhosis. If I knew these things prior to taking the telaprevir, I might have added them, and perhaps I would have responded. And SVR, what are your comments on these 2 commonly available, potentially life-changing compounds in our everyday life in terms of treatment with compounds for hepatitis C?
Yeah. So the coffee story is interesting. We're learning more and more about the benefits of coffee. It's probably not caffeine, it's probably other components of coffee. There's studies in the liver world which suggest it slows disease progression and maybe even reduces the chance of hepatocellular carcinoma or liver cancer. I think the studies documenting an impact on antiviral response with coffee, I think are limited. Vitamin D, the studies show that a large proportion of patients with chronic hepatitis C, particularly with advanced fibrosis, are vitamin D deficient. Lots of people are vitamin D deficient these days, but certainly patients who meet those criteria are more often vitamin D deficient. And there's some small studies with dual therapy, with interferon and ribavirin, but without the direct-acting antiviral agents, which suggests maybe supplementing with vitamin D can improve response rates. I'm a bit skeptical that that's going to make a difference with triple therapy because these antivirals are so potent compared to dual therapy. That said, if we check vitamin D levels on all our patients pre-treatment, and if they're vitamin D deficient, we're treating them for that reason. As opposed to, let's say, if you're not vitamin D deficient, giving them extra vitamin D with treatment in the hope of getting a higher rate of response. Maybe something there, but I think the studies of triple therapy aren't yet available.
Okay, just one last question.
Just really quick question. Is there any relationship between the development of rashes and the development of autoimmunity?
You mean subsequent development of autoimmunity or past history of autoimmunity?
Either.
Not that I've experienced. Remember, you can get rash from ribavirin, and then you get rash from these predominantly telaprevir. It's to my knowledge, is not thought to be an autoimmune-mediated phenomenon.
Okay, thank you. And I think what's happened when it comes to the new modalities of protease inhibitors, what it actually is doing is opening up the door for research. And it's amazing. I often used to say to my patients, one day there will be a patch for this disease. Maybe one day there will be. Thank you, Dr. Myers.